Hi everyone, it's Derek here from Med. Welcome to today's video in which we'll take a look at gout. This is a really common condition that usually affects the distal joints and is due to a buildup of uric acid within these joints. This can lead to quite a lot of pain, usually affecting the first metatarsophalangeal joint. Now, there's quite a few risk factors. Some of our lifestyle risk factors include excessive alcohol intake and excessive red meat consumption. Certain conditions also increase the risk of gout, including CKD, diabetes, and myeloproliferative disorders. When it comes to gout, I think a really effective thing to do is to break it all down into 3 steps. So firstly, we can look at our acute management of patients with this condition. Secondly, we can look at what we do at the follow-up appointment at 4 to 6 weeks. And lastly, we can look at our prevention and long-term management of this condition. So in the acute phase of an initial attack, we usually go for our first line treatment with a course of colchicine 500 micrograms 2 to 4 times a day. Alternatively, non-steroidals can also be used in addition to a PPI. Second line treatment for the acute phase includes the use of steroids. Prednisolone 35 mg can be given once daily for 5 days. We also have non-pharmacological methods which you can use in addition to the medication. This includes rest, elevation, and the use of ice packs. We can consider referring a patient to secondary care if, despite the use of our non-steroidals or oral steroids and colchicine, they still have ongoing symptoms. Also remember that a patient that is already on urate lowering therapies that has an acute attack of gout should still continue taking it. We then follow up the patient at 4 to 6 weeks after the initial acute attack. Bloods can be done at this stage for uric acid levels and our UNEs. Bloods are usually done at this 4 to 6 week follow-up point because uric acid levels can be abnormally low in an acute attack because all the crystals have been deposited into the affected joint. So waiting until this period of time allows us to get a really good, clear picture. Supporting patients to make lifestyle changes is also really important because a lot of them tend to have several cardiovascular risk factors such as metabolic disease, raised cholesterol, diabetes, and hypertension. So it is important that these are managed. We can then look at how we prevent a patient from having future attacks of gout. Lifelong urate lowering therapies are offered to anyone with a first attack of gout. NICE guidance suggests a treat to target approach. In order to determine the correct dose of urate lowering therapy for the patient, we start them at a low dose and then we titrate it in line with our serum urate levels. So we aim for a serum urate to be less than 300 in our patients that have gouty tophi. We can aim for it to be less than 360 in everyone else. Annual bloods, including our urate levels and renal function, should be checked once target levels are achieved. In relation to our urate lowering medications, allopurinol is our first line treatment and is preferential for those patients who have a history of cardiovascular disease. Febuxostat can also be used as second line. So leave a comment below if you found it helpful to break up this topic into its 3 main parts. So we've looked at our approach to the initial assessment of an acute attack. We've also looked at what we do at the follow-up appointment. And lastly, we thought about our prevention and long-term management of this condition. As always, if you found it helpful, don't forget to leave a like and subscribe. Also, make sure you check out the rest of the videos on this channel. Until the next time, I'll see you soon.